Emma, welcome everybody who's joining us as the doors open. Welcome. I see Carol and Levon and Sami and Vincent. Welcome everybody. Welcome. Literally like the doors are opening and people are coming in. Fabulous. Okay, so we're going to kick off and try and keep us to time. So welcome everybody. I'm sure many of you know me. I'm Nadine Ferris-France. I'm the Executive Director of the Irish Global Health Network, and we also host and run the ESTHER Ireland programme. Welcome to the 5th Partnership Forum. I cannot actually believe that this is the 5th Partnership Forum. It's incredible. It seems like it was only yesterday that it was the first one. Incredible. What's amazing about today for those of us who are in Ireland is, as always, the weather has been the same for every single one of these. It is a wet and windy day. So the good news is we don't have to leave our homes to actually be here. So that's one good thing for us today. In the last 5 years, 5 years on, we now have 10 ESTHER accredited partnerships, and we've so far supported over 30 partners with our small grant fund. So we're really delighted just to have accompanied and walked on the journey with many of the partners that we've been in touch with, and we've learned so much. We continue to learn so much from the innovations from each of the partners in the context that you're working with. Particularly this year, I think we've been able to see that very clearly. In terms of housekeeping, everyone's so familiar with Zoom these days. This is a webinar, so please question and answers in the question and answer function. Chat if you want to share something with us. We'd love to hear from you. We are recording this session and it's also on our YouTube channel going out live. So without further ado, I'm going to hand over to David Weekliam, who is the Director of the Global Health Programme in the HSE. David.
Thank you, Nadine, and good afternoon, everyone. I'm really delighted we're able to host our 5th Partnerships Forum despite all the challenges of COVID-19. It's always a great opportunity for us to come together, those of us involved and interested in partnerships, to network, to share, to learn together. And I know the issue is very different being online, but we can still manage, and that's great. And it's also shorter than other years, which we decided was necessary just with people under so much pressure with the added additional work with the pandemic. But sometimes less is more, and if we have less in quantity of time, we have, I think, more in quality. And we have a wonderful lineup today of panelists and presenters. And that's really my cue to be short in my introduction, so we can move on to hear from others. And I just want to briefly set the scene for today's meeting. And essentially, it's that to say our world has changed abruptly back in March, dramatically, and I would say changed forever. And when this pandemic is over, we'll all be working in a changed world with different needs and challenges. And our ways of working in partnerships and with our partners will inevitably be different. One thing I've learned during the pandemic is how effectively institutional health partnerships can work even when we can't travel. And from an Irish perspective, I think we can reflect very positively on how we've shown solidarity with our partners, despite all the demands that we have here with COVID. And I think we've seen how the pandemic has brought fresh attention to the challenges of improving health globally. We've seen things like the importance of global solidarity and working collectively and in coordination to tackle global health problems. And the need for us to provide particular support to countries with weak or fragile health systems. We're saying we're only as strong as the weakest link. And that also means a renewed effort to tackle health inequalities at global level and at country level. And the importance of building resilient health systems in all countries, every part of the world, that can withstand future shocks and challenges. And I think that points to the mutual benefit of partnerships between countries, which can learn from each other. So in all of this context, I think health partnerships are as important or more important than ever, and will be a vital approach in the coming decade as we strive for universal health coverage and better health for all by 2030. And our first session is going to be looking at this, the changing role for health partnerships. And then we've also seen how health partnerships have responded and adapted to COVID-19. We've seen flexibility, innovation, creativity, resourcefulness. And we've also seen new partnerships continue to spring up. And in the second session, we'll touch on this, hearing from new partnerships with links in Africa and Asia, and new approaches by established partnerships. So we've called this event A Bright Future for Health Partnerships, and I hope you get a renewed sense of this today. And on that note, I'm going to stop and hand back to Nadine.
Thank you, David, for being brief and clear. We're off to a great start, and welcome everybody who's just joined us to this community of people, individuals and institutions around health partnerships. So I'm delighted to hand over to our first moderator, Lorraine Murphy, known to many here. Lorraine enjoys many diverse roles. She's working as a quality improvement facilitator with the National Quality Improvement Team in the HSC, and that includes working with the Global Health Programme, where she's already been involved, quite a lot involved in supporting quality improvement programs in Mozambique and Ethiopia. So over to you, Lorraine.
Thanks, Nadine, and indeed thanks all for inviting me to moderate this session. It most certainly is a privilege, and particularly when we're talking about, you know, a changing role for health partnerships in a changed world, because I'd really only started to dip my toe in, you like, with international work and working with the lower income countries. And now we can see that we're working, as David had said, in a very different way. And I think COVID has certainly changed our expectations. I think it's changed our possibilities. But I think more than anything, it is presenting unique opportunities to start working differently, to build trust, build those relations in a very different and a very effective way. So I'm delighted to introduce Ben Sims. So Ben is the keynote speaker today on this session, and he's the CEO for the Tropical Health and Education Trust since 2015. So Ben has 30 years experience of working internationally with an emphasis on global health and disability work. So Ben's worked extensively across Africa, Europe, Latin America and Asia during this time. And he's been harnessing expertise from across the UK community, in the NHS and in specialist medical charities such as the Sue Ryder and Sense to benefit the development of health and social care in low and middle income countries. But for the past 15 years, Ben has been in leadership roles, building a very strong track record in advocacy and programme innovation, and working closely with the UK government departments and UN agencies. Ben's knowledge of the NGO sector is further informed by periods chairing bond working groups and taking active roles in health networks such as Stop AIDS, the network he directed from 2010 to 2015. Ben has led an active voluntary life in the UK throughout this time, serving as a counsellor and acting as a trustee of several charities. Ben became a fellow of the RSA in 2019 and has an MSc in Development Management from the Open University and an MA in History from Edinburgh University. So Ben, I'd like to welcome you for your presentation as keynote speaker on a changing role for health partnerships in a changing world.
Lorraine, thank you so much, and thank you to everyone for inviting me to talk today. I'm very excited to be here. I feel as if I'm amongst friends. I thoroughly disapprove of the fact that I'm having to sit in West London rather than in Dublin. So although we can point to some of the positives, my not being able to come to Dublin is one of the negatives. Can I just, first of all, by the way, congratulate Irish Aid. Yesterday, Irish Aid was recognised as being ranked #1 in terms of use of foreign aid. So that's quite an exciting position to hold. I'm the Chief Executive of FET, as Lorraine said, and here's a bit of background for those of you who don't know. Our passion is health partnerships. So our passion is those links between UK health institutions and health institutions in low and middle income countries. I think we've managed about 50 million euros worth of UK taxpayers' money to support this kind of approach over the last 10 years. We award grants, we run programs ourselves, and we try and think, and in other words, do the policy work. And I'm glad to say that some of our work through Johnson & Johnson grants that we manage have benefited Irish institutions such as the Western Health and Social Care Trust. So we are very much soulmates and partners to ESTHER and to the health partnership community in Ireland. We feel we learn from you. And that's why it's so good to be part of this today. So the past year has been really challenging, hasn't it? And the scale of the pandemic, I was reading the other day that there's an estimation that we've gone back 25 years in development in about 25 weeks. It's the biggest recession since 1870. There are 37 million more people thrust into extreme poverty. And it's not just a pandemic, is it? It's a syndemic, as Richard Horton was saying in The Lancet recently. And I like that recognition. It's not a global syndemic. If you're in New Zealand, you wouldn't know what I'm talking about. But if you're in the UK, you definitely know what I'm talking about, which is that the pandemic has had a different effect on different parts of our community. And that's why I find that syndemic word so useful. It's a recognition that not everyone is experiencing COVID-19 in the same way. But we've been here before, so this is not the first pandemic, is it? And Nadine, for example, knows well the HIV response. And you might ask ourselves, why has the world been so slow? Why have we stumbled into this? Anyone who's seen the Bill Gates warnings 2 years ago will know that we could have anticipated some of what we're experiencing. And there are huge challenges that we have in terms of building back better. We have some of these obstacles were identified in a presentation by Teresa Amado from Cambridge University recently, and she pointed to some of those obstacles that we still have to overcome. And they're reminders that I suppose our work in global health is both medical and health and technical, but it's also political. And we need to engage in that wider environment, don't we? As well as the skills exchange and knowledge exchange that we love most. Having said that, in recent days, it's been very, very exciting, isn't it? The timing of this conference is great. I mean, I'm just wondering though, we've seen the vaccine and the thoughts about vaccine are, did you see the stock exchange and how that responded in the UK? 18% drop in the value of Zoom shares versus a 40% gain in the value of Rolls-Royce, who of course make airplane engines. So we're not necessarily knowing whether we're moving on to a new normal or whether actually we'll just revert to an old normal. And I am enthusiast about the vaccine, and let's talk about that later. But just a note, Pfizer is not part of the COVAX facility, and it's the COVAX facility that will deliver access to vaccines for people, our friends in Africa and low middle income countries. But Biden was elected. And wasn't it wonderful, those moments when he read quoted these words from the Bible? It was just such an uplifting moment. And I don't know, the World Health Assembly is happening this week as well. And did you hear Dr. Tedros speak and the fluency that he spoke about his own grandchild that arrived 2 weeks ago? It is definitely something is shifting in a positive direction. And I wanted to focus on 5 areas where I think health partnerships really have got something to contribute to influencing whether we reach for a new normal or whether we return to an old normal. And the first thing is what David said, which is that thing about solidarity. I have to say, when the pandemic hit the UK in March, someone called me up and they said, Ben, what are people doing to respond to the pandemic and health partnerships? And I said, what are you talking about? You must be mad. They're all working on the front line of the health service in the UK. They haven't got time to think about the health partnership and the global health activity. Now, I was so wrong. I began to receive messages from people who said it's really grim here, but what's it like overseas? What's it like with our partners? And then they started to talk about some of the actions they were doing. And so the solidarity that's been expressed but at an individual level, complementing this global and national level that Dr. Tedros has asked for. The solidarity has been great. And I'm glad that THET has been able to support some of that with rapid, flexible grant making that has allowed people to continue to maintain those links and exchange those experiences. But it's hugely beneficial. By the way, some of the bidirectional change has been really interesting in UK context. In March, for example, I observed how a THET-supported training program developed with the National Resuscitation Council of Kenya was being used to train frontline staff at Torbay NHS staff. So it's a trust. So it's a reminder of how that reverse learning, how much we can learn from our partners in low middle income countries. The second thing is that adaptability. When the syndemic pandemic happened, we were working very hard on promoting good antimicrobial stewardship approaches. And what happened with that is a lot of the work had to stop, but it adapted, those partnerships adapted to look at ICU work, look at good practice. There's one example, which is a favorite, which is the Brighton-Lusaka pharmacy link, which led to an increase in production by 400% of alcohol-based hand rub. So this was something they'd been talking about. And when the pandemic happened, they were able to flex their response and scale up. And as also David mentioned, this theme of digitalization, Theatre's launched virtual volunteering, which is totally embracing the idea that you can do so much without travel. And we've got our first recruits to what we're calling virtual volunteering. We're also working on a digital platform which will allow for the exchange of information. I blush when I think about some of the trips I've done in my career. Lovely of you, Lorraine, to read out that entire biography, which made me blush a bit. But some of the trips I've done, really short term, you know, parachuting in and out, and are they as valid as I now realize? No. And so what we can achieve through digital means is absolutely fantastic. Health partnerships are responding also to that inequality agenda. And I'm particularly, I particularly enjoyed reading again Irish Aid's 2019 report, which has just been launched, which focuses on gender equality and women's empowerment. And THET has also been focusing on gender equality and social inclusion over the last year, and we've developed some toolkits for health partnerships, which we hope are useful. But we've also had Black Lives Matter in the middle of this pandemic. And Black Lives Matter, of course, born of the US, but hugely relevant also to our society in the UK. And that and getting comfortable with the idea that there's racism in our institutions, in our approaches, I think has been a really important gift of the Black Lives Matter movement. And I think it encourages us, emboldens us to really examine our approaches. One way we're doing that is by learning to much better value the contribution diaspora NHS staff are making. Lorraine's given me 1 minute. And the final area is the quality UHC agenda, which is the themes that Dr. Sham Said, who's well known by us all and much admired by us all, he emphasized. And this is where health partnerships are just making such a contribution. So we know that 5 million excess deaths are a result of poor quality care versus the 3.6 million, which are a result of a lack of access to care. And it's in the space of quality UHC that health partnerships really make a fantastic difference. So I try to focus on 5 themes, which are really substantial areas of work by health partnerships happening in Ireland and happening in the UK and elsewhere. Thank you for allowing me to speak at such speed, and thank you for having me at this event.
Many thanks, Ben. And I just note there, we talk about the quality UHC. I think that theme falls beautifully into our next presenter, Omema Salid, who's with a representative of the Southern Partners at the board of ESTHER Alliances for Global Health Partnerships. And she's also Vice President for Academic Affairs at ACFAD University for Women in Sudan. So Omema is an Associate Professor of Molecular Biology at the university, and she's vast experience in facilitating institutional health partnerships between ACFAD University and other regional and international institutions. She was the coordinator of the successful institutional partnership on physiotherapy professional development and promotion between ACFAD University for Women, Western Norway University of Applied Sciences, the University of Western Cape in South Africa, and the Comprehensive Community-Based Rehabilitation in Tanzania. And currently Omema is the coordinator of ACFAD University at the Consortium of Global Health Universities, partnering with the Maastricht University in the Netherlands, McMaster University in Canada, the Manipal University in India, Thammasat University in Thailand, and University College of Southwest Norway and Rosario University in Colombia. So today, Umaima will be presenting to us on the needs of the partnership from developing countries.
Thank you, Lorraine. Good evening, my colleagues and attendees. I'm going to present very short presentation as I have only 10 minutes. Before I start presenting, I would like to send words of thanks to my colleagues and partners in different countries with whom I communicated to consolidate this presentation. Can you share the presentation, please? Lorraine? Yeah. Okay. So this presentation had been discussed thoroughly with my colleagues in different countries from Uganda, Ethiopia, Mozambique, South Africa, Tanzania, and South Sudan. So what's the needs of the partnerships from developing countries? We emphasize the credentials for health partnerships, and as the speakers, David and Ben, they mentioned, we are in a changing world. And this pandemic really uncovered a lot of deficiencies and fragile health and different groups that are highly affected with this pandemic. So we thought the partnership should address, in the future time, should address the needs of vulnerable populations in developing country. And the vulnerable populations, definitely they differ from a developing country to another. And now this pandemic, it really uncovered the needs of the vulnerable populations, like disabled, like the children, the women in rural areas, who doesn't have access to a very simple test to test for COVID. So these are really vulnerable populations. I think they need to be addressed in the future for the partnerships. And the other thing, we think the partnership should provide quality healthcare in developing country. And of course, for the long term, it should impact the country healthcare policy. Next slide, please. So looking to the first one, addressing the needs of vulnerable populations, we think this is the role of the Southern partners. They need to identify the vulnerable groups in the country. And this is very crucial. As being a developing country, you know that we have different vulnerable groups, and the majority of the census is vulnerable groups. Conduct health needs assessment of vulnerable groups, formulate the partnership goal and objectives to positively impact the health needs of vulnerable groups. Next slide. So to provide quality healthcare, this is really around the health resources, the human resources. And as you can see, the cubic for the universal health coverage, it's really emphasizing the role of health human resources. And this is a major and important factor. As you know, in developing countries, there is a scarcity in human resources at the different professions. So we think adapting this model and putting in mind when developing or planning for any partnership, this should be one of the core or fundamental part of a partnership. Next slide, please. And the other thing we recommend for any institutional partnership, recommend a model of three-win partnership structure. Of course, the northern, and we have the country institution, which is in the urban area, and there should be a rural institution. And this will minimize the movement and the access of and improve the access of the vulnerable groups who really suffer from lack of services in their rural areas. So three-win partnership structure is very important. We think this is the time to look into this and to be adapted in the different partnership. Next slide, please. Of course, most important is the outcome and the impact of the partnership. There should be, if we are looking to the sustainability of a partnership, there we should address the theory of change. And the theory of change is very fundamental. Otherwise, the impact will be very, very limited, cannot be measured, and it will not be sustained. So, so these are the credentials for any partnership we are looking forward, and this is very important for the future partnerships. Next slide. Okay, thank you. Thank you.
Thank you so much, Umaima. And again, it is great to see how that your presentation and Ben's presentation, and again, you could see the linkages, and you can see that a lot of the same messages are being delivered across. We talk about vulnerable populations, we're talking about solidarity and the impact of partnerships and that quality UHC. Thank you very much. I'd like to introduce you now to Dorte. Dorte Petit is from the head of program in Switzerland, the ESTHER program in Switzerland, and she's a public health expert with more than 15 years experience of international experience in different areas, including neglected tropical diseases, HIV and AIDS, sexual and reproductive health and immunization, and she's a particular interest in health system strengthening. Dorte received a Master of Public Health from the University of Bielefeld. I think my pronunciation is terrible. Apologies, Dorte, Germany. And a Doctor of Public Health from the London School of Hygiene and Tropical Medicine, in which she conducted a qualitative case study on the health system recovery after conflict in Liberia. Dorte joined ESTHER Switzerland as the head of the program in November 2019. And today she will present to us on ESTHER Switzerland's new strategy and its connection to health system strengthening. I think you're still on mute, Dorte. Thanks.
Thank you very much, Lorraine. Are you able to see the slide on the screen?
We'll bring those up for you now. Thanks.
They should be on my screen.
Yes, we can see ESTHER Switzerland. And then...
Yeah, perfect. Great, thank you very much. So I'm very happy to be here this afternoon and to have the opportunity to talk about ESTHER Switzerland's strategy 2020 to 2024 and its link to health system strengthening. And before I start talking about our strategy, I would like to give credit to David, who is on the ESTHER Switzerland Steering Committee and who was heavily involved in the development of the strategy. And I should also tell you that when I started the daunting task of writing the very first draft of that strategy, I actually used the ESTHER Ireland strategy for inspiration. So before talking about what we want to do, let me just give you a quick overview of where we're coming from. So we had a first phase of ESTHER Switzerland from 2015 to 2019, which was financed by the Swiss government. And that's where we planted the seed for ESTHER Switzerland. And this phase was characterized by a focus on sexual and reproductive health and HIV, and that's just for historical reasons why ESTHER was created in the first place, and relatively short timeframes for the partnership. So the funding cycles for partnerships was about 12 to 18 months. And our monitoring and evaluation focused mainly on the project results. So there wasn't really an evaluation of the quality of the partnerships. It was really looking at the project level only. And we had an external evaluation of the phase one. And what we heard from the partners in the low and middle income countries was they were happy to receive the ESTHER funding, but they didn't really see a great difference to any other kind of development funding. And I think that's also linked to the fact that the partnerships often still followed a rather conventional development approach, with the Swiss partners being more in the lead And Umaima just mentioned that it's really the partners from the South who should be in the driver's seat, who should formulate the partnership's goals and objectives. So I think that's something that still takes time and that we're working on the strategy now. And just to talk about the context, as we've heard, we are in a changing environment, and the time while we were writing the strategy was entirely dominated by COVID-19. However, I wouldn't say that the pandemic had a direct influence on our strategy. I think it rather confirmed the direction that we wanted to take. So we see that we need strong health systems to face this kind of pandemic in order to be able to keep essential health services going. And there is a risk to focus on COVID-19, and that can be at the expense of other health areas. And at the same time, I think this pandemic is a great opportunity for mutual learning. We are all in this together for the first time, so it's a good opportunity to actually learn from each other. So where do we want to be in 2024? We would like to support long-term partnerships with a long-term vision, which contribute to research and policy making, which ultimately should lead to health system strengthening. So how do we want to do that? We are using the model from WHO, Twinning Partnerships for Improvement, as our model for the ESTHER strategy. So we want to focus on creating these long-term partnerships, and I think ESTHER Switzerland can learn a lot from ESTHER Ireland. I think you're much ahead of us in terms of looking at the quality of the partnerships and having this long-term vision. And then to work on improvement at a local level. And what I said before about the monitoring and evaluation, that in the first phase we focused on that. So it was the improvement at the project level. But what we want to foster now is to spread the improvement further to not only one health facility, but to the district level, the regional level, the national level. So that means that we have put a lot of emphasis on communication and also on research. So just to illustrate what this could look like. So if, for example, we are conducting a training of health staff in a facility, in order to spread that, there could be training of trainers to have that also in other facilities. And then to move further up, to contribute to policy briefs, and to have this eventually leading also to health system strengthening by really inputting to the curriculum of the health staff. So that's just one example. And how do you want to do this? I think one of the missions of ESTHER should be to challenge the conventional development thinking. And as I said, I think ESTHER Ireland is ahead of us in this. So we want to move beyond the financial support that we provide to institutional health partnerships, and to also create opportunities for learning. And here I need to thank Ben Sims for a great TED conference a few weeks ago, which was for me a great source of inspiration of the type of topics that we need to address in these learning opportunities. So I'm thinking about webinars about power dimensions in institutional health partnerships and bias in learning. So these are just examples. So just to reiterate, I wouldn't say that the current pandemic had a direct impact on our strategy, but really confirmed the strategic direction that we want to take in terms of really not focusing on a disease, but widening our scope. And so right now we don't have a specific health aspect that we are emphasizing. We really want to look at health systems. And we use the health topics more as an entry point rather than a defining factor of the partnerships. And if we look at the partnerships that we selected for funding earlier this year, all of them want to follow through with what they had planned, so nobody changed. The only modifications that took place was obviously delays in implementation and also modification in their approach, so less travel and more distance teaching and learning. So now we have a few challenges ahead of us. We want to transform the seed from phase 1 into a healthy plant. And this means that we have to secure long-term funding. And also we need to connect the Swiss hospitals with ESTHER Switzerland. We know that there are a lot of health partnerships with hospitals in Switzerland that are already doing these kind of partnerships, but they don't know about ESTHER and we don't know them yet. So we are working on a mapping exercise to find them and on a communication strategy. And then we need to create a pool of experts to actually provide the kind of learning that I talked about earlier. And here I particularly hope to be able to count also on the ESTHER Alliance. Thank you very much. I'm happy to take questions.
Thank you so much, Dorothy. And again, a very insightful presentation sharing your experiences of developing your strategy for ESTHER Switzerland. And we have a first question in there from Yvonne Finn, and it goes to all panelists. So Ben, I might direct this to you first, and that is, the work of the NS partnership should be directed by the needs of the South partner. Do the panelists think there is a need to provide leadership training to our colleagues in the Southern partner institution?
First person you should ask is probably our Southern partner.
Yes, so Mema, yes, indeed, indeed.
Shall I go after Mema?
Yes, please.
Yes, I think you're right. There should be a training for the leadership and furthermore on the assessment of the communities. I think this is very crucial, so that we have partnerships that address to the different communities that who are in need. So yes, I'm sure that this is very important. Thank you.
Thank you,
so,
Mema.
And I would certainly agree that I suppose leadership training in some respects is about empowering people to take on leadership and to influence. And I'm sure that's something that is a priority. By the way, it's also something that every UK volunteer talks about when they return. There's something, isn't there, about working across borders, working in an environment in which you're not confident, which feeds that kind of confidence that allows you to take on leadership roles. So top of the list in terms of what UK volunteers talk about is their improved leadership skills when they return back into the UK.
Thank you, Ben. Dorothy, would you like to add to Ben or Mema's reply?
Sure. I was just thinking about one example. That I was talking to one partnership that we are supporting right now, and they're clearly the partner from the low and middle income country is in the driver's seat, and but it was still something that was presented as it was more presented as if the lead was coming automatically from Switzerland. So I think it's really a learning on both sides to take on that role, to be in the driver's seat. And so yeah, I mean, leadership training, yes, I think that is something, or not just leadership training, but really a critical appraisal of how we work together from both sides.
Thank you. And could I extend that question right out to the group, please? Would anyone like to add to those comments? No?
Yes.
David?
Yes, no,
Right.
just briefly, Chad, I agree with what others have said. And in my experience, where we've seen successful partnerships and where there's been success within the partner countries, it's where we have strong local leadership. And I think I would see then a key feature of partnerships is to help and facilitate people to express that leadership. And it's about, as Ben said, about enabling. And if we can somehow be an ingredient in that, in just helping to untap the leadership potential that's there, in order that then they can lead their own responses, which is, of course, what's essential for sustainable change.
David, could I ask you on that? Because I suppose knowing some of the work that you've been involved with, what were the enablers that you particularly noticed, I suppose, had the greatest impact and around in enabling those leaders to flourish? So what enablers within the country themselves, and what enablers then from the partnership countries?
Well, one of the enablers I've seen is providing training, so that gives greater confidence technically, that people are confident in the area that they're working in. So if we're working, for instance, in quality improvement, that people feel they're well equipped and know the right approaches. But I think part of what we've tried to do through the partnership is just to acknowledge and praise good leadership and encourage people to be leaders, and that so that people have that confidence to where they may be working in very low resource settings and maybe aren't sure what they can really do to make a difference, just to really remind people that they can be very effective as in their roles, and to acknowledge that, and then to be supporting each other. So I think peer support is very valuable. So I think we've seen with our partners is how they support each other through encouraging each other, sharing learning, so that they're building each other up constantly. So I think they'd be some of the key things.
Thanks, yeah. Thanks, David. We have a question from Peter to Omema. And Peter's asking, would Omema say a little more about rural versus urban differences in healthcare in the global south, please?
Yes, I can take one example, for example, Sudan. The rural areas, the health services in the rural areas are almost, I don't want to say lacking, but very, very scarce. And when I say I presented the model, I mean that most of the partnerships that it's taking place are in urban institutions, like in the capital, and always you feel that the capitals of most African countries are like mega cities, because most of the people, they get displaced from the rural areas and move to urban to searching for health services. And even if we talk, at one time the country is trying to use the telemedicine, is trying to use all these digitalization facilities, but it is not effective because of the infrastructure. It's all very weak, very fragile. And so the structure of the model is that like the urban institution is driving and giving support to the rural one. So, and of course, this is all under the umbrella of the Northern partner. And so that the services and the benefit of the partnership is not limited to a certain urban area. So that's what I mean about this model. Yeah. Thank you.
That's great. Thank you. So I'd like to invite the floor, so to speak, if they would like to make any comments before we conclude this session. No? Well, I'd just like to thank my sincerest thanks to Ben, to Omema, and to Dorte. Thank you very much. And And now I'd like to hand over to Hala Ali, who's the coordinator of ESTHER Ireland and the ESTHER Alliance for Global Health Partnerships. Thank you.
Thank you, Lorraine, and thank you very much for this great session and all those inputs from the speakers. So I will introduce the winners, or I will announce the winners for the ESTHER Ireland Unsung Hero Award 2020. I'm very happy and honored to announce those winners, and this award is to recognize the incredible work done by ESTHER Ireland Partnerships and to shine a light on individuals who have worked hard to show consistent, unshakable commitment to health partnerships that are involved in. We received amazing nominations from really amazing partners, and it was really difficult and huge decision to make. And we received nominations from partners or colleagues of partners who work in Tanzania, Sudan, Kenya, Mozambique, and they have done amazing work. It was a very difficult decision, but we had to choose only two, one from an institution in Ireland and one from a health institution in the southern countries. So the first Unsung Hero Award winner for 2020 from the Southern Partners is Dr. Elenia Macamo Amado. Sorry for the pronunciation, but the first winner is Dr. Elenia Macamo Amado, consultant obstetrician from Maputo Central Hospital in Mozambique. Dr. Elena, she is involved in Mozambique Ministry of Health and Health Service Executive, HSC, in Ireland Partnership. Elenia was the Assistant Director for Medical Services at the Mozambique Ministry of Health from 2015 to 2020. In this role, she had responsibility for the country hospital services, and in August, she stepped down from the role and returned to the clinical work. Elenia's commitment first and foremost was to serve the people of Mozambique and deliver better health care. She worked very hard to achieve that objective. Elenia was also committed to the partnership with the HSC and used every opportunity to avail of support to improve health services in Mozambique. She recognized the value of working in partnership and regularly reminded us that on our own, we go faster. Together, we go further. Her commitment inspired us in the HSC and gave us the encouragement and motivation we need to maintain our commitment. These are words from Elenia's colleagues. So I would like to welcome Elenia, and we will hear from her in a bit. And now also, I would like to announce also the second winner we have, which is from an Irish health institution. The second winner for the Unsung Hero Award 2020 is Dr. Sami Ahmad. Dr. Sami Ahmad is retired consultant pediatrician and has been involved in Cork University Maternity Hospital and Omdurman Maternity Hospital in Sudan partnership. Dr. Sami has been a truly artery in teaching of 24,000 midwives in Sudan, distributed over the 18 states, covering a rural population of 25 million through his work and help in the training of 4,000 health providers and 150 instructor courses. Nevertheless, he continued to have a future passion in the goal reaching the whole Sudan with his project. Dr. Sami has contributed his passion and care along, of course, with his colleague in partnership to achieve with the twinning program, maternal mortality has fallen from 216 in 2003 to 33 in 2007. He has been a wonderful part of developing the leadership in Sudan to save lives, such as contributing to creating a positive and supportive learning environment, as well as building new network to help achieve better outcomes for patients and for the team. And with Dr. Sami's effort, there have been an exceptional growth of teaching in Sudan. He continues to review his goals and how he can make things better. So congratulations to Dr. Elenia and congratulations to Dr. Sami. And I would like to welcome Dr. Elenia for a few words.
Good afternoon, everyone. And thank you so much for this opportunity to be with you with this partnership, which help us too much. I would like, first of all, the second thing to say thank you for all my colleagues. Of course, they are not here, but I believe I will have the opportunity to speak with them and say that this award, it's not mine, it's for everyone. It's for Mozambique, it's for all the health professionals who are providing healthcare, and especially for all that are implementing this project of improving quality. I told when I came to Ireland that time that together we can go further. Together we can have better results. We can make difference. That's what we did when we made this memorandum of understanding with the HSC, and we had the support with the ESTHER and the embassy. And the HSC has been a good partnership with us. And we believe that if we still together, we can have really more better results that we had achieved from now. Have been for more than 5 years that we are working together, and sometimes it seems that we have started yesterday. But we started in 2014, and since that we have developed this partnership, which have improved. And we trained the staff of the our hospital. We started the training of the staff of the health minister of health. And now we are trying to go to the health facility, which is our chance. Now with the pandemic, it has been a challenge. I believe it's also for all of them, of us. But as we are compromised, I think we can go more than we have achieved now. And the big challenge now for us, I think, it's to maintain the gains that we have. And more than maintain the gains, I think it's to spread what we have started to the other hospitals. So thank you so much for all of you that have supported Mozambique, especially for HSC. Also, it's a good partnership for us. Thank you so much.
Thank you very much for being also part of ESTHER Ireland family, and we really appreciate all the work they have done, all the great work. Congratulations again. And now I would like to welcome Dr. Sami Ahmad.
Thank you very much. Can you hear me?
Congratulations.
Can you hear me?
Yes. Yes.
Thank you very much. Really, it's a pleasure and it's an honor to get this award. And I would like to thank all the ESTHER members, David, Hala, all of you. Thank you very much for the nomination. Thank you for the award. And it's important to say that all the success and all what we achieved came from working as a team. And I think it's important to mention on the top of this team is my friend and my colleague, Professor Tony Ryan, and Dr. Monem Hamid in Sudan, and Dr. Marwan Omar and Sister Hind. And there is a lot of members. I cannot tell you all of them or say the names of all of them. A lot of obstetricians and midwives and ambulance personnel and fire brigade and engineers. They all really came together and they work as a team to give us the final results of success. And we are proud that we managed to do these projects, and still we're continuing with the two projects, Helping Baby Breathe and the neonatal registration program. We had a lot of difficulties and obstacles, and I'm sure you know, because of the totalitarian government or regime in Sudan and the dictatorship government, but all this finished, and now we're happy that with the new youth revolution, the door is open for more projects, open for more ideas, open for more support and help to any organization and any group of people who want to give help to our people there. The previous regime left a very strange situation regarding the health services. It was not good, and it became worse and very difficult. So I'm very happy to say thank you to you all, and thank you very much for your nomination and award. Thank you. Thank you very much.
Congratulations again, and really thank you for all the great work. Thank you. Now I will hand it over to you, Nadine.
Great, and congratulations, Elenia and Sami. We're absolutely delighted for you, and thank you for inspiring us, continuing to inspire us in all the work that you do. So we are going to move from Mozambique and from Sudan and Cork now to Mayo, and I'm going to hand over to Maeve Nivwenon, who again will be known to many. She's a consultant obstetrician and gynecologist in Mayo University Hospital, and we're very grateful that she's taken some time out from delivering babies to actually be with us today. Apart from her great work in Mayo General Hospital, Maeve has volunteered with Brighter Communities in Kenya since 2005 on rural maternal survival interventions at both community and health level facility. At the two levels there, with Brighter Communities and with the management teams in Londiani sub-country and Mayo University hospitals. She's led the partnership development since its inception from 2007 to date, and we continue to learn so much from you. Over to you, Maeve. Thank you.
Thank you very much, Nadine. I'm delighted to be at this webinar today. I think the host might have to show my video. Thank you. Thank you very much. Just to confirm that the sound is there, please.
Yes.
Yes, thank you very much. So I'm delighted to facilitate this session on the Irish partnerships forging new links and taking some new approaches. And it's quite exciting to hear from 4 partners in this next session, and each partner will talk for 7 minutes. It'll be interesting to think about the commonality of our partnerships, particularly under the guidance of ESTHER Ireland, the uniqueness of each partnership, what we've learned this year with the collegiality of working together and collaborating in a different, challenging time, and to celebrate the exciting evolution of these partnerships, often with a little sprinkling of serendipity along the way. So I'd like to now introduce the first presentation. We're going to hear about the partnership from Irish and Sudanese scientists that are studying gut health. And we're going to hear about microbiome science in Sudan. And as I left labour ward this morning, I was thinking how great it is that the newborn is colonized at birth, and how we then choose our feeding of our children to encourage that microbiome to further develop. But of course, as we move into non-communicable disease, and our partnerships are often featuring that we will hear about, and the microbiome plays a very important role that we need to hear more about. Sami will present for the partnership. She graduated with a bachelor's degree in dental surgery from University College Cork. So we do go back to Cork, as well as her Sudanese links. She received her master's in 2012 in the field of oral medicine. She is a third-year PhD student in UCC, and she has experience of working both in Africa and Europe, and is one of the members dedicated to this partnership. And I'd like to hand over to her now.
Hello, and thank you very much. And you can all hear me?
Yes, thank you.
Thank you. It's really a great opportunity to present today, and such wonderful speakers so far and yet to come. And I'm really very excited about being here and for representing my team, which, as we all have seen, teamwork is really the key. And now, can you see the screen here?
Yes, thank you.
So I'm here to present today on the partnership that has just begun on between the National Ribat University in Khartoum and APC Microbiome Institute in Cork. And this is really one of the wonderful partnerships, I suppose I would really like to say thank you and congratulations to Dr. Sami and Dr. Elenia, where they have shown success in Africa and how a partnership can really help the population. And so really basing this success, this partnership came as a dream and started. And what I would like to focus on, in the minutes that you have offered today, is a little bit about the partnership itself and who are the partners. What is the microbiome science, essentially? You have mentioned a great introduction about it there. And what is its importance for Ireland and for Sudan, and what welfare it can provide to a population such as Sudan. As Dr. Umaima at the start has mentioned, a population that is really suffering essentially in many areas, in certain areas. And also, of course, I will explain a little bit about our current achievements and some of our future prospects. So this presentation is going to be a little bit about the understanding of microbiome science, and then essentially why we're at it and why we're hoping for a better future for Sudan because of it. And now explaining the partners, interestingly, both establishments have begun at very similar times. The National Rabat University was established in 2000 and is one of the biggest universities in Sudan, very similar to University of Khartoum and Sudanese Technology. They're really the three main universities in Sudan, many accreditations and bachelors. And the APC Microbiome Institute was established in 2003, and it's affiliated with University College Cork, Tagisk, and CIT, with many members really, and very constitutive and very strong foundation. And therefore, it's a pleasure really to have these two institutions come together in this partnership. And then the next idea is to tell you about microbiome science. If I asked everyone who is sharing today what you might think of when you hear the word microbiome, maybe some will say bacteria, as you mentioned, it is about gut health, it's about other areas of health, is it about humans? And so the idea of this slide is just to provide some of the main ideas and to, I suppose, get people interested about it. Essentially, the microbiome, we're more microbiome than human cells, and it is really influenced, particularly at birth, for example. It's the collection of all areas of the microorganism, so it's not just bacteria, essentially, and therefore that means there's a lot of exploration to understand it. The science behind it is relatively new, but very not complicated, but very accurate, and needs a specific, mechanisms and specific science behind it. And really the idea is to look at what the microbiome is, the characterization and how it interacts, not just with itself, what's out there, but with the human body. Interestingly, we actually wouldn't be healthy without a healthy microbiome. Studies have shown it's important in gaining weight, in hormones, in chronic diseases and non-communicable diseases. It has a role to play, and even things like depression and anxiety. And although the microbiome might be similar in people, it's actually very unique, so much so that science has now shown it's almost like a fingerprint or a unique thumbprint of a person. And indeed, this presentation is in nowhere trying to, or has the time to talk about the microbiome in detail. And in the panelist area, you might find an interesting National Geographic article that, if someone is interested, you can further explore what the microbiome is really about. But this is the idea behind our partnership, the science behind it. Indeed, taking this on further, what is the benefit, not just to Sudan, but to Ireland, to many areas? Well, bioinformatics and the computational biology that comes from studying microbiome is really, is really fascinating in terms of the offerings it can provide to human health, to agriculture, animal industry, the environment. And all of these is something that Sudan is really needing to grasp its hands on. Microbiome can look at tackling diseases, the new therapeutics that are out there, things like personalized medicine, automated nutrition, things like that. Dr. Umaima Saleh, for example, mentioned the need for looking at the rural areas, sustainable farming. Food production is another area I'll be talking a little bit more about on what we have done so far in it, how we can get these areas to improve really for the benefit of the population of Sudan. And indeed, not to mention, I know ESTHER and also APC and the Ministry of Health and areas in Sudan are looking at all of this with the Sustainable United Nations Development Goals in mind. And indeed, the microbiome touches on a lot of these, particularly Goal 3, for example, good wealth and well-being, and Goal 17, where we actually have partnerships in order to improve health. And so the microbiome not only touches a specific area, as we mentioned in the application, it touches all the areas that anyone can think about for the improvement of mankind, essentially. And therefore, now focusing in on some of our objectives, we created a logical outcome model, which is really showing what the inputs of the institutions can provide separately and then what they can do together. And the idea is that the APC in itself has extensive experience and infrastructure really for microbiome science, while as areas in the Sudan have a very good competent personnel and human resource, but unfortunately lacking, as Dr. Sami mentioned, some of the problems in Sudan in terms of financing research and problems with the government has created this lag in technology. And when they come together, the idea is that they create this better science and well-being. And even when I talk about business, I mean something for the population benefit rather than private. But it's really important also to think about that area. And so these are just some of our objectives in order to bring about microbiome science in Sudan and to help in the merging of what can become undiscovered that can also benefit Irish science and Irish medical fields and industry. And indeed, one of the unique areas of this partnership, it's definitely not the first partnership in Sudan, but it might be one of the first that directly has a specific research field. And this is important. It reflects, as mentioned previously, the vital urgency that Sudan needs to get a hold of research. And I can show you what this means. If you just do a PubMed, which is where all the papers, I suppose, you can find, you will look at the real lag in microbiome research. I mean, just looking at Sudan microbiome, it really only comes up with a handful of research, and some of these are not the top technology. Whereas if you look at Ireland microbiome, there's a huge number of research out there, and it's probably actually more than that. The APC has published more than that. But then when you look at, for example, something like Ireland International Microbiome, Ireland still has a lot to learn, essentially, and especially from areas like Africa. And so although Ireland is really an expansion and great field and pioneer microbiome, it needs the work of something like Africa or Sudan to get the right and to get the up-to-date information on the microbiome. And so it's imperative to collect this type of data. And so this collaboration merges the two partnerships together, the benefits for Sudan, but also the benefits for Ireland. And one can talk, there are specifics about how the Sudanese partnership can help the microbiome for Ireland, things like trying to get what the microbiome is actually, the functionality and the diversity. We actually are on the tip of the iceberg of the amount of information we know. And taking an area like Africa, the diversity of the microbiome and the uniqueness and the things that have not been discovered are really a stepping stone for what Ireland needs to know. And this is
Amal, at this point, I might just ask you to draw to a conclusion. We're reaching the end of time.
Yes, sure. Well, really, just the idea here is that the scientific organization of the APC brings about many different areas, and we have already touched upon the diet and the microbes. There is a project now that is underway, and then also the Sudan is one of the least developed countries. When you look at the poverty context in Sudan, we're hoping that the microbiome science will really benefit Sudan in this area, and then bringing that together. This is another area the panelists will have a reference. What is the microbiome and the missing link, essentially? Again, the United Nations have brought together. We also I had a quick slide on the maternal health and how authors here that are in the membership team, Catherine Stanton and Paul Ross, affecting the gut microbiota, and how essentially it is important to look at a specific area. We chose suppose to start with maternal health. These are just some of the references to I suppose support the health of the microbiome. These are all the different areas that we are looking at essentially in the future, and you know, our dreams are high as the baobab tree that is very unique to the Sudan, and we've already touched upon areas. So the grant will help really Sudan to evolve, moving from like poor technology or culture based, essentially old fashioned, to very new, or what we call next generation sequencing. And finally, we really have been very busy in terms of looking at this team together, creating a regular and strong educational and vibrant communication. And we are very happy. We've published our first publication of the partnership, we are glad to say, and we're looking at one of the cultural problems, which is the smokeless tobacco, and have already got a lot of data on that. And finally, the memorandum of understanding, we're also very happy to report about it. And I'd like to end this just on the future plans, hopefully when the COVID is over, bilateral visits and looking at further work in terms of personal approach. And really, I hope if you ever visit the Sudan, the Al-Mugran, which is where the Blue Nile meets the White Nile, as you can see, is a very unique geographic naturistic collaboration. And this is an idea of what we're trying to bring together. I'd like to also thank the partnership teams, the names here. And, you know, this partnership is showing that if we work together, it's a beginning, but if we keep it going, hopefully it will be a success. So we've a lot to do. So thank you.
Amal, thank you very, very much for that comprehensive introduction to microbiome science. I hear that we're only scratching the surface. Thank you. We'll return to the subject in the questions and answers later on. We'll move along now to our next speaker, who's going to talk about the Partnership on Global Brain Health Initiative with Bangladesh. Irasima Leroy, and apologies for my pronunciation, is Associate Professor in Geriatric Psychiatry with academic postings at Trinity College Dublin and in St. James's Hospital in Dublin for clinical practice. She's also allied with University of Manchester. She's involved in the bringing together the collaboration on a project in Bangladesh to reduce the impact on dementia in the country's aging population. And perhaps in a number of years' time, the gut microbiome will contribute to her work as well. And we will hear from her shortly. From the project and partnership point of view, we're looking at understanding the links among hearing, vision, and cognitive impairment in older people, whether enhancement can improve the outcome for dementia. And it's exciting that she is building these collaborations for dementia research in Bangladesh, Pakistan, India, and leading the roadmap for dementia in Pakistan. I'll hand over now to Irasima to hear her partnership update.
Thank you very much for that introduction. I'll just make sure that my slides are shared. Okay. Thank you very much. So first of all, thank you very much for the opportunity to present here, as well as, of course, the funding that we received to start off this partnership, which I'm sure will be very fruitful as we move forward under the concept of brain health. I have to start my video. Hang on a minute here. Is my video on now? Okay. All right. So first of all, who are we? Let me just move that out of the way. So our Bengali-Irish partnership is actually a Bengali-Irish-Swedish partnership. And it started off with myself and Dr. Sanjeev Saha here in the middle, who is one of our global brain health fellows who was here in Dublin for a year working with me. And we have now expanded to involve colleagues in Sweden, where he's gone back to, and of course in Bangladesh. So we are partnering with the Alzheimer's Society of Bangladesh, as well as colleagues in Bogura in Bangladesh, so representing the rural side of Bangladesh, Dr. Sharia Farooq, Dr. Raizul Khan, who's in Stockholm in Sweden and has links in Dhaka, and Dr. Badrul Islam in Dhaka as well. And so this is a sort of a multifaceted partnership with the Global Brain Health Institute, which actually sits over 2 locations here in Dublin, as well as the University of California, San Francisco, as well as our hospital partners in Dhaka, the Sir William Beveridge Foundation in Dhaka, the Neurology Academy, which is a health education partnership in the UK, and as I mentioned, the Alzheimer's Society of Bangladesh as well. So, what is the objective of our partnership? Our objective is to develop a Bangladesh-Ireland-Swedish collaboration to enhance knowledge, awareness, and practice for dementia among healthcare professionals in Bangladesh. And the grant will start in January, and we have 12 months to achieve some of our initial outputs. And why is this important? Because of the global challenge of dementia in lower and middle income countries. As some people may be aware, more than 2/3 of the world's 50 million people who live with dementia live in lower and middle income countries. Stigma is extremely high. The lack of understanding of dementia as being outside of the normal aging process is significant. And of course, there are limited health and social care ecosystems for older people's mental and cognitive health, or I should say, general health. And of course, family members, particularly women or informal and untrained carers, deliver dementia care in home settings, which can inflict a tremendous burden on systems. So, brain health challenges in South Asia are significant. And the reason why the time is so opportune is because recent evidence has come out, which suggests that up to 50%, 56% of the world's, or at least in South Asian, burden of dementia is potentially preventable if we look at the key social determinants of health related to brain health. So, for example, as you can see in this picture, about brain injury and head trauma, about air quality, about food, in other words, diabetes, hypertension, obesity, and all these factors, if addressed, can actually decrease the incidence and the prevalence of dementia. Now, what is happening in terms of brain health resources in Bangladesh? As you can see here, a population of over 164 million people. The percentage of the population over the age of 60 is actually relatively small. So this is quite a young population, but young populations get older. And with the increase in expected lifespan, of course, issues such as dementia and increasing non-communicable diseases related to aging will soon be very much to the fore. In terms of the health resources, neurologists, psychogeriatricians, long-term care facilities, adult daycare centers, relatively non-existent. However, there is an opportunity in that dementia is highlighted in the government's plan of action for non-communicable diseases. So we see a small in to start talking about dementia. So our overall aim really is about improving awareness and understanding of dementia amongst healthcare professionals. The primary objectives to achieve this aim are, first of all, to draw up the nature of the partnership amongst our organizations for the purpose of the actions. We then want to perform a learning needs analysis in professionals regarding dementia awareness, knowledge, and practice, and the future national dementia plan. Many, if not most countries now have a national dementia plan. Bangladesh doesn't. We then want to undertake a dementia training camp for clinicians. Now, I should say that this was the original plan. COVID, of course, has changed this. And in fact, now we're looking at a much more flexible and probably sustainable model, thinking about toolkits as templates and co-adapting modules for the Bangladeshi context in terms of dementia education for professionals. So our planned outputs, first of all, to develop a core team of dementia leaders to provide training for colleagues in their home settings, to locally adapt training materials and toolkits for use by dementia leaders in their local context, to develop a collaboration of Bangladeshi professionals focused on this particular topic, working alongside international experts in the field, and also to develop a theory of change strategy for developing the training. What have we done so far? We've done a lot of talking, actually, and a lot of Zoom calls. So, new collaborations with Bangladeshi-based colleagues, new collaborations with Swedish-based colleagues who have in-reach into Bangladesh. We've identified a pilot site where we want to start off with an initial core training team in which to help develop our modules and adapt the training. We're starting a plan of regular meetings to frame the objectives, the tasks, the deliverables, and the milestones. We're also scoping the most appropriate model of training and service delivery in the context, and of course, building our theory of change. So some of the key elements that we've started to look at, we're looking at the MH gap, the mental health gap model developed by the World Health Organization surrounding dementia diagnosis, and linking this in with the best practice that we have of flexible dementia diagnostic models from Sweden and the UK. We also have a model of a distributed model of mental health care from rural Nepal, which we're looking at and potentially incorporating. Our key idea is to start small and build using iterative models of change, using PDSA cycles, which I'll mention in a moment. And we have a few principles that are underpinning our work. The key aspect here, of course, is task sharing, and this is extremely important in anything to do with mental health because of the low resource that we have in terms of mental health or brain health professionals. Whatever we do has to be resource sparing, including virtual mentorship and training. And again, COVID-19 is a tremendous opportunity to allow us to test that out. Another key bit is that we have to be driven by primary care. And I think this is a very interesting opportunity for bidirectional learning. Dementia care in general, in high-income countries such as the UK and Ireland, has been very much sitting in secondary care. So myself, for example, as a consultant geriatric psychiatrist, I sit in a hospital centre in secondary care, waiting for referrals from primary care. This is not a sustainable model for a condition that's only growing in prevalence like dementia. So in Bangladesh, we need to do it right and start off with primary care, where the care and the diagnosis of dementia really belongs. Sustainability, of course, is a key principle. A mentorship model is a key principle. And of course, underpinning this is looking for a balanced partnership. In other words, based on co-creation, respect, bidirectional learning. And our guidance in this is based on some recent work we've done in terms of developing a charter of conduct for balanced collaborations in international partnerships for dementia research. And the reason why this is important is because we're talking about dementia partnerships for the first time. This is a new area because populations in many lower and middle income countries are now aging for the first time. This wasn't a priority before, but now it's a priority. And my last slide here, just to demonstrate one of the approaches we may take using the PDSA cycle based on improvement science. In other words, that we potentially will start with one small team thinking about planning, acting, doing and studying it, and then adapting, building it, spreading it, until eventually we have what Dr. Sami Ahmad has, in other words, 24,000 professionals trained for dementia. So that's our vision and our goal. So Dr. Ahmed has set the standard here. So thank you very much for your attention, and please don't hesitate to contact us. And I hope that a year from now we can tell you what we've achieved with our 24,000 people being trained up. Thank you very much.
Thank you very much, Shema. Certainly, with all the structures and the modelling that you've presented, there's no reason why we shouldn't hear about 24,000 in 1 year's time. Perhaps in the questions and answers, then we can hear a little bit about the three win that Omema mentioned earlier. Certainly, the distributive model for rural practice will be interesting to come back to. In the interest of having all the presentations first, I'll move on to the next partnership, and we'll keep that extra minute or two for the questions. So the third partnership is the one that I'm most familiar with. The Mayo University Hospital partnered with Luntiani, now Sub-County Hospital, and I'll be pleased to welcome Damaris Chepkamboy in a few moments to present the partnership update. This partnership is established initially as an institutional partnership, but nested in a development programme facilitated by the NGO Brighter Communities. And this year, the updated partnership activity that has a lot of the foundation work was done by Yvonne Finn, who's online with us today, brought together two academic partners into the group, NUI Galway and Kenyatta University. So we're going to move to Damaris, who's currently managing programs and administration in Brighter Communities in Luntiani. She's responsible for coordinating the programs and administrative duties. Her background degree is in strategic management, and she has a keen interest in healthcare and public health. So I'll hand over to Damaris. Caribou, Damaris.
Thank you so much. Good evening, everyone. Thank you, Maeve, for the wonderful introduction. I will go straight to the overview of our partnership. kindly put up my first slide, Maeve.
Damaris, so your first slide, we'll just reverse back to one previous slide if you don't mind, Hala. Thank you.
Okay.
Thank you.
Thank you so much. The next slide, kindly. Okay, this is a brief overview of the partnership between Mayo. Kindly go back to the overview. Yeah, thank you so much. So the partnership between Mayo University Hospital and Breta Communities Worldwide, together with Londiani Sub-County Hospital, which is an hospital in Kericho County in Kenya, and the hospital serves a population of around 280,000. And the partnership was started in the year 2009. Its main focus was in maternal survival, and I'm happy to say that it resulted in building of an operation theater, a maternal shelter, and an improved antenatal care tracker system. Next slide. Hello.
Yes, the slide is up, Damaris. There might be some slight delay, I think, in the image. Damaris, we're just having an audio delay. If there's a bandwidth issue, will we switch to audio and stop the visual?
Okay.
Try again now. I can have you back.
Thank you.
Try as you are again.
Okay, thank you. As you can see in the photos, there is a capacity development training going on in Londiani Sub-County Hospital. The link team's visit to Kenya and Ireland, and the operation theater, which was enabled by the partnership. Next slide, please. This partnership was strengthened in 2009, the year 2019, and it was new academic partners were added, and that is NUI Galway University in Ireland and Kenyatta University in Nairobi, Kenya. For the next 5 years, the partnership will focus on 3 thematic areas as per the needs assessment carried out and finalized in February 2020. The areas are trauma, non-communicable disease, and perinatal, maternal, and newborn health. On the slide, you can see a photo of the first trauma training, which happened in February 2020. That is before Corona hit the world. Next slide, please. We all know that COVID-19 came up with its needs, and there was obvious concern across the partnership of how each was managing. And here in Kenya, Londiani Sub-County Hospital and Breta Communities Worldwide carried out a needs assessment and came up with 4 priority areas, and that is the healthcare workers' safety, health facilities readiness, healthcare workers' capacity development, and community sensitization, which ended up in pivoting of most programs by Breta Communities Worldwide so as to focus on flattening of the curve. Next slide, please. Through the partnership, we have managed to carry out several healthcare workers' capacity development workshops across the country. And these workshops focused on 4 main areas on COVID-19, that is infection prevention and control, identifying, isolating, and caring for patients, contact tracing, and home-based care. Ireland was affected before Kenya, and the information, experience, and learnings shared by Mayo University Hospital helps strengthen the workshops. We have an ongoing training right now for the new healthcare workers in Londiani Sub-County Hospital. Next slide, please. No one was prepared for the COVID-19 all over the world. including Londiani Sub-County Hospital. Brighter Communities Worldwide came in to support the setting up of a 5-bed isolation center, that is by renovating an existing building, and with financial support from volunteers who had visited Kenya previously and before COVID-19. Next slide, please. We all know that the safety of our healthcare workers is very important for the process of flattening the curve. Unfortunately, here in Kenya, we have a major challenge of provision of PPEs. Through the ESTHER grant we received, Londiani Sub-County Hospital have been provided with a number of them that will keep them going for a while, but there is still need for more. We are grateful to ESTHER Alliance for that. Thank you. Next slide. The safer the community is, the less the pressure on the healthcare system. Brighter Communities Worldwide, working with the Ministry of Health and funding from Irish Aid, have done sensitizations on hand washing and COVID-19 prevention in several households, and we are hoping to do more. The sensitizations involve explaining what COVID-19 is, measures of prevention, which are mainly hand washing and mask wearing. We also get to teach them how to make local hand washing facilities, the tipi-tapis. As you can see in the picture, the yellow container. Yeah, and make them aware of importance of keeping safe. Next slide, please. Looking into the future, the capacity development is ongoing and will focus on other thematic areas that are crucial and will involve learning sharing sessions online for all partners involved and how they are managing so far. I'm glad to say all these are made possible by the support we have for each other during this time. On that note, I would like to say thank you and keep safe. Thank you.
Damaris Asante Sana, thank you very much for your presentation, and particularly the interesting pivot in COVID times, which we will also hear about in the next presentation from the Gori Malawi partnership. We'll come back to that same theme that you identified on the safer community means a stronger health system, that Irachema had also identified as a problem within the dementia service, when we come into the questions and answers. So I'd like to move on to our fourth and final partnership presentation for this part of the session. The Gori Malawi partnership is working with the Health Service Executive Global Health Programme, the Irish College of General Practitioners, and ESTHER Ireland to produce 14 accessible learning videos to help healthcare practitioners in lower income countries with their COVID response. And there has been an overwhelming response to these views worldwide. So I'm pleased to introduce Peter Harrington, a full-time GP in Gori in the southeast of Ireland, who had experience as a medical officer in a mission hospital in Kenya and academic general practice in Dublin, and then a return to Malawi moving on 5 years ago with his practice partner, Joe Gallagher, to establish the Gori Malawi Health Partnership in Muzuzu. And I'm very pleased to see the addition of Roisin Nicola Rua, a graphic designer and a graduate of the National College of Art and Design in Dublin, who has worked as a freelance graphic designer and has helped with animation, logo design, video, sound editing, illustration and print. And we've just lost electricity here, but we'll keep going on battery for a while. Today she'll be giving a presentation on the animation series that she helped along with the Gori Malawi partnership. And perhaps we'll find a way of how we can tap into Roisin's resources, and we'll see her work at the end of the presentation. So I'll hand over to Peter Harrington, I think is going first, and then to Roisin.
Thank you, Maeve. Can you hear me, guys?
Yes, we can, Peter.
You can, great, okay. And I hope you can see my slides.
No, Peter, we can't see them.
Okay, give me a second here now. This is the part that will go belly up. Give me a second here. Share screening options, Hannah, then give me a sec.
Okay.
Share, give me a sec now. This might work.
Yes,
how's
Peter.
that working?
Yes, perfect, thank you.
Okay. So thanks, folks, for asking us to speak. I'm going to go first, and then Roisin will come in on her aspect. So many of you will know what we do. We're the Gorey Malawi Health Partnership, and we are a GP surgery in Gorey County, Wexford, that is paired with a strongly ESTHER supported partnership with St. John's Hospital, Mazuzu, in the north of Malawi. And we work primarily in the area of NCDs, working with mentoring of local non-physician healthcare workers, and also working at institutional level to improve management of NCDs. And we do in-country visits, and we do some remote mentoring, or at least that's the way it was, of course, until March. And as our previous speakers have said, suddenly in March, we were all trapped in our surgeries and wondering what was happening in a variety of places. And one of the great reaches was the Irish Global Health Network's Friday webinars. And at one of these webinars, Joe and myself watched it together, and we realized we need to start repurposing our partnership. It's no longer about NCDs. We need to start looking at COVID today and how we can assist today. So we sent out a WhatsApp, and we contacted our partners, who were grateful for our reach out. And as Elenia pointed out, it was useful because we met COVID-19, we knew something about it. So we asked, how can we help? And 3 areas were recognized as being necessary. One was to try and divert some finance for increasing resilience, as you saw the same sort of things that you saw, tippy taps, hand sanitizers, public awareness campaigns to try and improve it locally. We sent out a resource package of items that would be difficult to source in Malawi. And then we came to the third ask, which is about assistance in education. And essentially the question they were asked was, there's so much stuff out there, we're waiting for this epidemic to arrive, we're a little confused, some of the recommendations are a little cumbersome, hard to understand what you think we might need to do in Malawi. And we also were aware we're trapped in Gorey, and we realized, of course, that Malawi, which is a poor country, it mightn't have running water or electricity reliably, but there's always a 3G phone mast nearby. And of course, increasingly, healthcare workers have smartphones, and WhatsApp is used to disseminate. And so we came up with the idea of a brief series of educational podcasts, maybe 3 or 4 minutes long, on different aspects of COVID-19. These could be sent via Facebook, and so we could track the penetration, but they were also embedded in a WhatsApp, so they could be sent along by WhatsApp fairly easily. So that was the idea, and then we sat down and thought, let's try and put out some aims and objectives and curriculum here. So this was our thinking, and if any of you are thinking of doing something similar for your own projects, this is what might be useful to consider. Who is your audience? How will you achieve penetration? And what will success look like for you at the end of this? We put by a curriculum, 14 different curriculum areas. We enlisted some colleagues in the Irish College of General Practitioners who were helpful. So thanks to Anne Phelan and to Mark Wheeler for their contributions to 2 of the 14 videos, which are very much their babies. We consulted WHO for a variety of advice relevant to the Global South. We put together our curriculum. We asked for editorial support both in the north and the south to make sure it was kosher. And at that point, then the idea was we would create a PowerPoint, we would compose a verbatim that was spoken, and that would allow our project manager and animator to advance each of the videos. Now that was the theory, but who were all these people? It was Joe and myself, by and large, in Gorey, with some additional support. So the serendipity that Maeve talked about came into play there. We gave David Weekly a ring and said, David, would you mind being our northern editor? And not only was he, of course, delighted to assist as always, but he said, do you know what? Maybe we could get some money from the HSE to assist with these. So before too long, we had a team. We thought our partnership was with Malawi, but in fact, we have partners waiting in Ireland to assist us as well. So we're delighted that about a week later, we're having a Zoom with Hala, Nadine and David. And ultimately, this is a sort of a broader partnership, not just GORI, but also the HSE Global Health Programme, the ICGP, as I mentioned, and then the Irish Global Health Network and ESTHER Ireland. So suddenly we have Hala, who is our project manager, and Roisin, who you'll hear about in a moment, as our animator. We put together 14 videos on a variety of areas: institutional readiness, maintaining health services, essential services, protecting health workers through PPE, through hand washing, a variety on clinical care, including palliative care and clinical assessment of patients, and finally one on myths and facts. And then, as I mentioned, we had Anne Phelan did one on maintaining mental health in our healthcare workers, and on albinism, in keeping with the other ESTHER supported partnership on albinism. So we launched very proudly, I can't remember, sometime late May, and we waited for this to disseminate and realized, of course, it didn't really go very far, partly because, of course, WhatsApp costs. In generally, it's not spread by Wi-Fi, because Wi-Fi is spread by 3G, and it costs small amounts of money, but significant amounts in Malawi. So it didn't really go very far. And then you'll notice, very different from the COVID wave, we suddenly got a boost, but this happened because we decided to boost it. So Facebook, again, thanks to the HSE for additional support, we launched through promotion via Facebook, targeting essentially non-physician healthcare workers living near large rural urban centres, rather, in a variety of sub-Saharan African countries. And suddenly, as of yesterday, we've 1.9 million videos playing in a variety of locations, not just in sub-Saharan Africa, but mostly there. So we're delighted with that to be a penetration. Now, what it leads to behaviour change is a whole different question. We also got some interest from the public health response in Malawi, and some of the videos are embedded in the Malawi public health education, which is being disseminated there as we speak. So that's kind of what we did. A bit more about the nuts and bolts now from Roisin. Roisin, I'm going to continue to use slides. You're going to speak, I hope.
Perfect. Thank you very much, Peter. Basically, I will just be briefly talking about how working on this video series and how I went about it from an animator's perspective. So yeah, just firstly, it was brilliant, like, as a designer, to be able to use your skills to do something that is, that will help people, and luckily I had a really great team to work with. So I'll just be talking about preparation, the software, the time and cost in making videos like this, just on a practical level, how we did it, and how it could be repeated again. So then for the first slide, yeah, so basically preparation, it was brilliant, because Dr. Peter Harrington and Dr. Joe Gallagher both had the verbatim for almost all of the videos finished before I had even started on animating. So that was really helpful to have it just prepared in advance. And another thing that's really helpful to have prepared in advance is the audio voiceovers. So Hala Ali was brilliant. She found Elias from Malawi, who volunteered to do the voiceovers for the video, for the videos. And so it's brilliant to have just the audio voiceovers recorded and ready to, edited and ready to go before you begin animating. And it's brilliant to consider beforehand your content and your audience and target group. And so that was Doctors Peter and Joe were brilliant in, they had all of this, prepared in advance, so that by the time I began, working with them, that they knew exactly what they wanted and, who it was for. And that was really helpful for me, just to know, you know, how it should look, and you know that it's educational, and definitely all of just knowing the content and audience group is really you know, you can just put the design, you know, correct design for what's needed. So for the next slide there, Peter, thank you. So for the software for this project, we used Powtoon. So it was my first time using Powtoon, and I'd definitely recommend it because it's extremely, it's basically an online animating software that is just very user friendly. And even though it was my first time using it, it was very quick to get to know how to use it. For beginners, it's a brilliant program to use. As it has just like, you know, and it's very, it's brilliant if you're under time pressure, as we were with this project, because it has just ready-made animation, you know, characters, small titled animations that are just really helpful, as we wanted to get these videos, you know, out there as soon as possible, as, you know, before COVID-19 had hit Africa, as it already had started to in Europe at that stage. Next was the Noun project. That was an online, it's a website that you can download icons from. So for some, you know, Powtoon did have some ready-made animations, but it didn't have, you know, some imagery or visuals that would be relevant to our videos, but that weren't already there. So that was useful just to download icons that you could then animate in Powtoon. And I also made some of my own icons in Adobe Illustrator. So that was that. And then Audacity is an online audio editing software. So that's actually just free online, and that was and it's very user friendly as well. So that was brilliant just for editing the audio. And we used WhatsApp, which was brilliant because we could, even though we're in Ireland and Elias, our voiceover, you know, he was in Malawi at the time, but it was a brilliant way to be in touch, as he could send the, you know, WhatsApp, the voiceover recordings to us via WhatsApp. And we also, just another side note is that we asked him, just instead of, you know, recording the whole video's voiceover in one take, just to split it up into small segments of, and that way we could, you know, just edit them together in Audacity. And it was just really, that was a really useful way. Yeah, so the next slide there, Peter. So then time. So basically, so with animation, it does take, like, you know, it's quite time consuming. So one, you know, 3 to 5 minute video could take up to, you know, between 1 or 3 weeks to make, depending on what software and all that you're using. So I definitely would recommend Powtoon, as that was a really, just with just the pre-made, like, small animations, it's really helpful if you are under a time pressure. And just another point is that the first video will always take the longest, as you're just kind of making the design decisions, you know, for the series, what looks good. You want it to be able to communicate the information well. And so definitely the first, you know, video or two did take a bit longer, and then you can just apply that design then to the rest of the videos. So that, you know, it definitely gets faster as you go along. And I also think the quality got better as we went along, as we, you know, I got used to using the software. And, you know, I think, you know, getting great feedback, you know, from doctors Peter and Joe and Hala really helped to make the videos better as we went along. And then just to save time, again, would just be to prepare your audio in advance, because if you have the audios ready recorded, it's just really helpful for an animator, because if we change the audio halfway through, I have to again change the animation. And then also, just one point was, in order to save time, it's great to keep it as a small team, because it was essentially the 4 of us, Hala, Peter, Joe and myself. And, you know, it's just the smaller the team, definitely it's more efficient, and you save a lot of time as the more people that are involved. You know, people might have differing opinions, and you know, definitely you're just waiting for feedback and things. So we definitely found that like having a small group work on the project was, you know, really great for time. And so the next oh yeah,
we'll have to draw to a close there if we'd like to
perfect,
see your work, if we could see the video, and then we do have to finish promptly, so just to get some time for
perfect.
questions.
Thank you.
But it would be lovely to share this resource of the knowledge that you're sharing with us, and thank you to Peter as well. So you're bringing us to your video now.
Yeah, I think Hala is going to share. Hala, yeah.
I am Dr. Jesse Shihana. I'm the hospital director of St. John's Hospital based in Mzuzu, Malawi. St. John's Hospital is a mission hospital under the Diocese of Mzuzu. Our partners, the Gori Malawi Health Partnership, together with the key advisors and in keeping with WHO guidelines, have created these videos to assist institutions in sub-Saharan Africa countries to cope with the COVID-19 epidemic. This is a rapidly changing area, and we plan to update these as information becomes available. What follows is a series of brief video podcasts about 3 minutes long to assist health facilities in low-resource settings to prepare for the arrival of COVID-19. Featured topics are displayed. If you have found these videos helpful, please forward to any other healthcare workers you know using Facebook or WhatsApp. Preparation is essential to prevent us from being overwhelmed by COVID-19. Solidarity with our colleagues will help to protect us all.
Thank you very much to Peter Harrington and to Roisin Nicola Rui for the update on their partnership. What wonderful work, and the power of animation is quite amazing. There's one question in the chat room: is English the only language that's been used so far, or are there other languages available?
Roisin, do you want to talk about how easy it would be to convert the format into other languages? It is only in English at the moment, but that's not, they're open source, so they're easily changed. But Roisin, from your point of view, how easy would it be to change?
Yes, so it's actually it's not very difficult, or it wouldn't take too much time at all to just readjust it to a new voiceover. So I know that Hala had begun to create some translations into Arabic, and essentially all that's required is just to re-record in whichever language, and once you have your audio ready, just to adjust the animation, which doesn't take much time or effort. It's very easy, so it's definitely something we should look into.
Thank you very much. So we just have a few moments for questions and answers. So if I can thank all our panelists, and if they would like to put on their video and microphones again. So we have Amal Sami on the gut and microbiome science, Irachemil Roy and the dementia prevention program. We have Damaris and Chepkamoy from Lundiani, and we have our final two speakers. Now that we've heard from all the partnerships and from our previous presentations in the first session, would we revert back to the question that was raised before on leadership in partnerships and how the training involves, or the learning in leadership evolves? I'll open it to the floor. If you'd like to sign or just jump right in.
If I could say two things on that, again, this is a key area, and we have already held, one of our resource persons is Sharon Morrow, who comes out to do quality workshops with our Malawian partners, and She was due to come with us in March, unfortunately, also, but obviously that was abandoned. So the emergence of leaders becomes key, because I think as you talk more and more and you engage more and more, you're looking for leaders to emerge from the group in Malawi, and that will only come with with engagement. And I suppose one of the things I miss about not being in the country is you actually, all the informal time spent with personnel, that's what creates the relationship, that creates the trust, that creates the growth, that somebody in Malawi puts their hand up and says, I think I can take this on, and you recognize that, and you I suppose onto it, and suddenly they're there taking responsibility. So that's the sad bit. You can't do it virtually. It's amazing. It's a relationship game, as we're discovering, and these relationships, we're missing out on the next set of relationships. So they're key, I think, and those workshops have been very, very useful.
I would like also just to tie in quickly with what Dr. Harrington mentioned, and also David Wickham, regards the enabling idea, and in terms of training. Leadership is very important, I think, in terms of training the Southern partners, for example, in the microbiome, in terms of providing the sustainability that is required for the science. And so it's really important when you look at a partnership, as people have mentioned here, how you can lead, but also how you can sustain and how you can manage, get people to manage it, so that it can work essentially and that it can continue. So I think a good leadership is in terms of how to get it there and to be able to sustain it in terms of training and in terms of providing that leadership role to the Southern partner effectively. Yeah.
And perhaps if I could link Damaris and Irachema, the scale up was one of the questions and the reach, and certainly embedding in the community and using the resources that are already there. Are there any comments or tips you'd like to give the group on how that looks, particularly at these COVID times, how the scale up was done in COVID times, what it used that already existed or what was created?
I'll jump in. Oh, go ahead.
Sorry.
Damaris, we'll go to you first, if that's okay.
Okay, we mainly used the community health volunteers, and they played a major role in the sensitization and preparedness for the prevention of COVID-19. So the community played a big role.
Thank you. Irachema?
Since we're at the beginning of our journey, I can't really comment on what we've done, but I just actually wanted to make a comment about the leadership. And I think one aspect of this is actually calling it out when you see it, because over this last period, we've seen some amazing examples of people adapting and being flexibility and rising to the occasion, doing incredible things to allow their group, their organization, their team to survive in unprecedented ways, and yet they don't recognize it as leadership. And when you reflect on it and you and back to people, you say, that was actually incredible what you achieved. I think that's very empowering. So it's leadership by experience, really.
And just one final comment on that. Peter mentioned remote mentoring before. So while there isn't that presence on the ground to name it in person, could we get it named by proxy? So then the remote mentoring could begin.
One of the things I just wanted to comment on our network is that you will have noticed that our Bangladeshi colleagues, 2 of them are sitting in Sweden. And so, there's a lot of talk about the brain drain, but actually this is an example of a brain gain, because they will continue to stay in Sweden, but they will be mentoring from afar using the technology, which is so easy, and giving back and being absolutely embedded in the community in the way that somebody who isn't originally from there cannot be. And that's something that I think we're really going to benefit from.
Will I open to Nadine now? Is it my time to hand back, as I'll just cast an final eye on the chat room to see if I've missed any questions. So I'd like to thank all the partner presentations this afternoon. I've learned an awful lot, and I've always got this column of ideas down the side when listening to this richness of presentation this afternoon, and particularly this year, as David said at the outset, that what can be done without travel, which of course is questioning our whole sustainability of our models. So I'll hand over to Nadine, and thank you to everybody and congratulations to everyone.
Thank you, Maeve, and thank you, everybody. It's so wonderful. It really does feel like a family, I have to say. It just feels like a family that continues to grow and grow and grow. And because of Zoom and even the nature of these events, we're just connected to people. And, you know, it's so lovely to have Damaris with us and Omema with us. And it's just, there's just not too many barriers. So it's wonderful. I think we're just going to finish up. We're going to try and finish on time, which only gives us a few minutes. But David, just a final word from you before I just want to show everybody a little bit about the grants, the new grant scheme that's opening. So just a couple of words from you, David. Thanks.
Yeah, thanks, Nadine. Yeah, I mean, it's just been a great afternoon. I mean, I said it earlier on, we didn't have a lot of time quantity, but we had quality. And boy, did we have quality this afternoon. And I've been just blown away, I think, by the breadth and the quality of the partnerships and the people involved. It's just been so wonderful. And I mean, I've been involved in partnerships a long time, but I keep learning. I've learned so much this afternoon, and I really value these opportunities for sharing and learning. And I think just today was a really good example of just such rich sharing. And there's lots of things, I think, to pick up from each other, both directly from the partnerships and then the very nice perspectives, broad perspectives from Dorte Ben and Omema, which I think really helps us in our work. And just too about the awards, I was just so pleased with the two people we were able to acknowledge today, Elenia and Sami. We talked about leadership. These people exemplify leadership, what leadership is about, what partnership is about, how people inspire people and work with people. And that was just so nice to see that today. So thank you. Just thank you for everyone who participated today. It was a great afternoon. Thank you.
Thank you, David. Thank you, everybody. So just leaving you with just two slides, just coming back to Esther and how we can support the partnerships. Maybe some people here have been inspired by partnerships. We just want to let you know that we're opening a new grant round, which will be open on the 16th of November. There will be two bands, band 1 for new partnerships and band 2 for established partnerships. And all the information is on our website. So welcome to continue to apply. We love to see the new partnerships and the innovations in the existing partnerships. And then just moving to the next slide, we would love that you stay connected to us. So if you really like what you're hearing around Esther, just make sure that you sign up. You can sign up on www.esther.ie and receive our bulletins. They don't come very often, so they don't clutter up your inbox, but it does keep us keep a way for us to stay connected. So we just want to say thank you so much. Please complete the evaluation if you can. We'd be absolutely thrilled if you would do that for us. It really helps us with these events to know, to know what works for you and what doesn't work. And we hope to see you. We will see you all soon. And maybe now with this kind of technology, we might be able to do more of these things, little and more often, which would be wonderful. So thank you to each and every one of you for joining us today. And we look forward to staying in touch. Bye, everybody.
Bye-bye.
Bye.
See you. Bye.
Thanks, everyone.
Thanks, guys. See you. Bye.
Bye. Thank you.